What's up, everybody? Welcome to the Better You Project, optimizing health, hormones, and aesthetics. And today I have one of my personal mentors who I've been working with so closely to develop the skills to be a great practitioner. I have Suzanne Furee, who is from Vine Medical in Alpharetta, Georgia. And she has a special interest in longevity medicine, peptide therapy, hormone, has taught me so many things. But more recently, she has really dug into some advanced therapy, specifically an advanced therapy called neurotherapy. Neurotherapy is amazing. As an innocent bystander, when I watched her in clinic and I watched her do these injections, is what is happening? And so what we're going to do today is we're going to break down what is neurotherapy down to those metabolites, because I think it's really important to understand what exactly and why is it working. And then we're going to talk about some of the clinical use cases as to, as practitioners, why would we consider this? And as patients, why would you be interested in doing something like this? Suzanne also hosts an amazing training program at Vine Medical. So if you are a practitioner and you're listening to this, at the end, we will talk about how to get set up with training. I don't train in this. I think I'm going to leave it to the experts like Suzanne and Melissa. Her nurse practitioner also trains in neurotherapy, and Suzanne and Melissa have come to UDirect Health to train all of our staff. And so today we're going to go ahead and break down neurotherapy. Are you ready?
Ready. So excited. Thank you, Lexi.
Yes. So Suzanne, talk a little bit about how did you get into neurotherapy and what were maybe some of the initial reactions when you started doing neurotherapy?
Well, the funny initial reaction that I remember this past weekend, we just finished a training this past weekend, is I had this like panic feeling every time I would do a stellate. Like, oh my gosh, I'm putting a needle in someone's neck. Like I'm panicked about doing it, right? And it probably took me about 50 of them to get over that panic feeling. It really did. Like I'm pretty confident, and I come from a background of doing like surgical procedures. I was a surgery resident for a year before I did my regular training, my family medicine training. So I feel pretty confident with procedures, but this one was just like, now it's so easy. It's rote. I've done thousands of them now, over 2,000 procedures now. So super easy. But when I first started, I remember feeling really anxious. And I remember, and I've watched my nurse practitioners go through that, like, I'm going to quit kind of fear. And I'm like, you got to push through, just one more. I promise that next one. So just know that as you go into doing this, if there's some story that we're telling ourselves that we're hurting people, but there's really very little you can do to hurt people when you know what landmarks you're looking for and you start just doing the procedure over and over. So I'm sure that's been your experience because you've done thousands of them too, I'm sure.
Yeah, it's definitely something where those first couple times you're like, okay, everyone, you and me, let's both take a deep breath.
Yeah.
Blow it out. I think for me, having an aesthetics background, I think adds a little bit, probably more layer of comfort in dexterity, hands, a 2-swivel aspiration. Because when you're in someone's face, you have to know the anatomy of, okay, here's your intraorbital foramen, here's your annular artery, here is the face. So it's kind of like, okay, let's bring everything down. But I'm going to be honest with you. First time I saw you do it, I'm like, wow. Like I didn't know what to think of it. Like many things that you do, I'm like, okay. That's how it is, which is why I love learning from you. So let's talk about what is neurotherapy, and specifically why in neurotherapy do we use procaine?
Okay, so neurotherapy is the century old. This was started back in the 1920s. Cocaine was the original anesthetic, and too many people became addicted to it, of course. So they changed the molecule into procaine. And procaine was the first anesthetic that didn't have the addictive potential. So it's a local anesthetic. It lasts about 20 minutes in the body. So no matter what we do, the worst case scenario, it lasts 20 minutes. The reason we choose procaine, the other reason we choose procaine is because of its metabolites. Number one is PABA, para-amino benzoate. And then the other one is DEAE, and it's escaping me. You probably have it in front of you what that stands for.
Is it diethylamino acetate? Diethylamino...
Ethanolamine?
Something.
Yes.
Like DEAA. Yes.
So it's The PABA and the DEAE have their own amazing benefits. And you probably have heard of using PABA. It's in a lot of sunscreens and works in that way topically. But we also use it internally. And the cool thing is damaged tissue does this, changes its electrical signal. So we talk about vibrational frequency and all that kind of stuff. Well, this is an energetic charge that changes in damaged tissue. So whatever we're talking about, if we're talking about a muscle injury after you've just done bicep curls or whatever the injury is, that tissue has a change in its electrical signal, which changes its ability to create proteins. It changes its ability to receive nutrients and its ability to remove toxins. And it's because the cell wall itself changes, and so the cell changes. So that whole tissue has that change in energy from effectively a negative 70 charge in a healthy cell to a negative 40 millivolt charge in a damaged tissue cell. That PABA will restore that cellular membrane integrity to allow for the toxins to be removed, the nutrients to be brought in. The cell can do all the things it's supposed to do, including creating proteins from the nucleus. So the cell functions more optimally when it has PABA, and damaged tissue heals. Then the DEAE helps to restore blood flow to the area. So you're typically, an area of damaged tissue is going to have a shrinkage, a vasoconstriction in the blood supply to the area. So even if you could receive nutrients, you're not getting the nutrients delivered to the area. That other one helps to increase the nutrient delivery to the area. So you're getting sort of 1-2 hit of all recovery, which is restoration of cellular membrane as well as restoration of blood flow to the area. You'll see if you ever do a little wheel, we call them quaddles in neural therapy, but wheel with procaine or a wheel with lidocaine. The lidocaine causes blanching of the skin, meaning it's vasoconstricting. And that's lidocaine, even if you don't put epinephrine in it, lidocaine by itself does that. The procaine actually causes extra redness around. So you're increasing that blood flow immediately. And this happens very quickly within seconds. So you're restoring blood flow, you're restoring energetic charge to the tissue, allowing things. So it's really just allowing the body its natural way to heal. So this is why we choose it. The others also are longer acting. So particularly if we're talking about injecting into a ganglion. So a ganglion is a cluster of nerves that come together sort of as a meeting before the meeting. The nerves come together, they have a little discussion, and then they send out messages to the rest of the body. And so if we infiltrate the area of that cluster of nerves, then we are allowing that cluster of nerves to change the signal that it sends to the rest of the body. So now procaine will quickly change that signal that it sends out and allow this sort of calming effect. The parasympathetic nervous system takes over. So 2 nervous systems, we have fight or flight, rest and digest, right? So we want that to be in balance where you can go back and forth between the 2 of those very simply and easily. If you're really hard stuck, if you think about like a seesaw and you're stuck in that sympathetic drive and you can't get into that parasympathetic, that's a problem. But the same would be true if you were stuck in parasympathetic. So the reason we like procaine is because of its short half-life. We're able to temporarily shift the autonomic nervous system to allow the parasympathetic to function, but we're not slamming it hard in the opposite direction where it's staying in that parasympathetic for a long time.
What do you feel like why patients maybe stay stuck or blocked? Like, what does that look like in patients that you see? I have an idea what you're going to say, but I want listeners to really understand when you see a patient come in and they either say certain things or they exhibit certain symptoms or they have this condition, it leads you to believe that they are either like blocked, have an interference field, or sympathetic dominant.
So it would be chronic pain is an easy one. That's a simple, obvious one. But then there's other people that we would do a ganglion treatment for where they just are it seems like stuck in a rut. You're having the same conversation with them every time you see them. You're saying, hey, I need you to take this supplement. And there's, you go back and they go, oh, I'm not doing it. And next time you see them again, oh, I'm not doing it. Next time, well, do you understand what the reason is that it would be valuable? Is there a financial reason why you can't afford it? Maybe I can find you a cheaper one. You have all these conversations and they're just not getting better. And then also their blood pressure staying high, their heart rate staying high, their despite all the things that you're doing, they're just not recovering from the things as you would expect. They're not responding to hormones, for example, as quickly as they should. So you give them estrogen, I would expect somebody to respond within about 48 hours to a dose of estrogen, not fully maybe, but they should have some response. And they're just like, no, hot flashes are persisting. I'm not sleeping at night. I sweat at night. I have insomnia. I feel anxious all the time. I can't, my thoughts aren't clear, those sort of things and then also some distractibility, attention difficulties. So a lot of patients who feel like they have ADD may also have, or may instead have, this sympathetic overdrive, the sympathetic dominance. And then you would see things like like heart disease, diabetes. All of those are diseases of benign prostatic hypertrophy. All of those are diseases of sympathetic overdrive.
Can you talk a little bit about maybe some of its clinical benefits in like patients with trauma? Earlier we had our call today and I'm like, what am I going to do with this patient? We've got this chronic infection. She's not getting better. And, you're advising, like, let's maybe see if she's had some sort of trauma, because trauma can create such an interference field from preventing from patients from getting better. So can you talk about how the impact of neurotherapy can improve patients who have either had childhood trauma, medical trauma, physical trauma, mental trauma? What would you see in that?
So probably my favorite story is, I have several, but one of them that comes to mind is a patient who maybe 15 or 20 years ago had a pretty traumatic childbirth. She was, they were having a lot of difficulty getting the baby out. The OB pressed on her abdomen, on the high part of her abdomen, trying to push the baby out from the top, or maybe the nurse did, and fractured her xiphoid process. So it just broke the bottom part of her breastbone, the bottom of the breast, just broke it off. So for the next couple of days, she was just moaning in pain, grabbing at her chest. Oh my gosh, I'm in so much pain. Everyone ignored her, said, you're just making it up. You're just exaggerating. They didn't give her anything extra for pain. She went on and ended up going home and never really had it addressed. And then a few years ago, so she just mentioned to someone that, oh yeah, I have this, and they did an x-ray, and yeah, she had a fractured xiphoid process. So that was probably her original pain. Well, so she comes to see us, and part of our exam is to do sort of a mild touching exam of a lot of commonly traumatic places. And we pressed on her xiphoid process, and she jumped off the table, just wow. And so we treated that with procaine, and she had an immediate emotional release. This is super common. Probably about 20% of our patients will have this emotional release in response to specifically trauma-related injections. And they have this emotional release. We call it a purging. And so we're cheering. We're going, yay, good job. This is excellent. Exactly what we want to see. This means we got it in the right spot, and you're doing exactly what we should do. So get it all out. Don't let it stay in there. And she had an excellent recovery and never had a problem again with her xiphoid process. So that isn't always the case. Often it requires multiple treatments, but this patient had a really great result. I have several patients with fairly significant childhood trauma-related PTSD today. One patient comes to mind who was treated. She came in multiple times for her PTSD, and when we started doing ganglion treatments on her, this sort of deeper shots for that cluster of nerves, she started to be able to drive herself to work. She used to have to use a dog to come with her to work to be able to attend the visits. She didn't need the dog to attend visits with her anymore. So it became this very different experience for her than it was originally, and that has continued to progress. Those bigger things like PTSD take longer, usually more like 12 to 18 treatments rather than 3 to 8 treatments. So, and we're talking usually weekly for most patients. I tell patients you got to give it at least 3 visits to try, because you might not have any response at all after the first one. Although most of my patients have some response after the first treatment, most patients will respond by the third. So if you commit to 3 and there's no response, well, then we need to look for something else. We need to do something else. When you talk about the interference field, there are multiple places where we may have experienced trauma. So for example, having your tonsils removed as a child is really scary, but it's particularly scary if you're left in the hospital all by yourself because of COVID and your parents aren't even allowed to come in the hospital with you after your tonsillectomy. It's particularly traumatic to have tubes put in your ear if you had if this was done without anesthesia in the doctor's office, etc. There's several other places. We consider the belly button, the umbilicus, to be one of the more common places. We consider the tonsils another common place where we'll need to treat. Any place where you have scars can be an interference field. Root canals can be an interference field, and all of that needs to be treated in order for whatever we're trying to accomplish to be effective.
Yeah. Yeah, definitely. Definitely the scars have been the most surprising in many patients as far as treating those. Can you talk a little bit about how maybe some of the benefits in patients specifically after COVID when they've lost their taste and smell? I think that is always very interesting on how that resets some of the lost.
I think it's really interesting. So we know that COVID itself gets into the nerves of olfaction. So if we can treat those with there are a couple of ganglions. So we like to do a sphenopalatine. And if you draw a line between the front of your face and if you sort of between these 2 lines, it's right there. It's easy to get through the side of the face. And if we treat that, and then we do a stellate, which is back behind this great big muscle, it lives right in here behind this great big muscle. If we can treat both of those, almost always will have a positive result from the COVID related things. We also can just use procaine in a nasal spray, and sometimes people will get results from that as well.
Yeah. Yeah. So we've gotten to do, I think, 3 or 4 cases of it. And the way that we did it, I think from the book that I had is we actually injected it kind of like how I would like filler, just like, right into not that you inject filler in the sinus areas, but I used like a 30 gauge, half an inch, 1%, and just like 0.2 cc's, and then up in the frontal sinuses. And then I massaged them, let them cook for 20 minutes and came back and they were able to smell. It's crazy. It is so, so crazy.
It's amazing. And you don't even have to do those big ganglion injections like you're talking about.
Yeah.
Often people will respond to just some under the skin. It gets taken up by the nerve. It goes back to the brain. The brain processes and sends the message back. Oh, everything's fine. You can stop doing what you were doing before.
Yes. So let's differentiate between quaddles and an actual like ganglion infiltration, because I think there's different ways that patients can receive and providers can inject it. So can you talk about why one might be more beneficial or one would work in a different way?
So the quaddles are little, we call them in medicine, we call them wheels. In neurotherapy, they call them quaddles. It's just where we take a tiny little needle, 30 gauge. It's the tiniest needle you've ever had put in your body. Probably what most of you guys use in facial injections, right? 30 gauge. Mm-hmm. And we just put it right under the skin and create just lift the skin up a little bit. All we're trying to do is get access to those skin nerves so that they can suck that back up into the body. That is just underneath the skin. So each little poke hurts a little bit. It's a tiny little stick, but they're pretty minor, and most people don't really feel them or don't mind them because they're tiny. The larger ganglion infiltrations actually go deep into the skin. So it depends on where we're going. Like I said, one of them's here. There's one that's back here in the neck. There's one in the belly that's right by the aorta. There's 2 in the pelvis. And what we're trying to do is just as these nerves come together, congregate together, and then go out to the rest of the body, we want to give them the message to send, which is everything's fine, calm down.
Yeah, perfect. So let's differentiate the difference between a stellate ganglion infiltration versus a stellate ganglion block, because I think one of the common things that practitioners when they come out of training and they tell someone who is not trained or is not familiar with this type of infiltration, all of a sudden, they're terrified, it's scared, this is not good medicine, all the things. And I think what's so great in the way that you've taught is you've actually showed the research. I'm not going to steal the thunder. I want you to explain how that is different.
So the standard American stellate ganglion block is done under imaging guidance, usually with fluoroscopy or ultrasound, and it's done with lidocaine or bupivacaine or ropivacaine,
which are steroids too. Steroids?
Yes, steroids.
Yeah.
Long acting. Mm-hmm. And what they're trying to do is shut down the expression of the sympathetic nervous system when they do that injection. What we're doing is infiltrating the ganglion with an amount of procaine. It gets taken up by that ganglion, by all the nerves in the ganglion. It's a quick response and a quick recovery. I don't want to infiltrate your stellate. My goal is not, again, to shut down that response, the sympathetic response. I'm just trying to allow the parasympathetic a chance to be heard. So we're just trying to just give that little irritation pause and allow it to come back up. We've had several patients who've gone through the standard American stellate ganglion block and that they did not respond. And then they came to us for a procaine infiltration and had a great response. There was a study that came out, I'm sorry, I forget the year, but it was comparing the two, the American stellate block and the what we do, the infiltration. And we do ours by landmarks. So that means I'm feeling into your neck. I know exactly where the C6 tubercle is. I know where it should be in the neck. I'm aligning your head and your neck in the right place. I'm not depending on my imaging to tell me where things are. I use my needle as a guide as well, because I can feel the difference in resistance as I go through one kind of tissue versus another. So I know where I'm going. I am aspirating to be sure I'm not in any major structures, and then I'm infiltrating. The research shows with the procedure that we do versus the standard American block, that the outcomes are nearly the same. In fact, slightly in favor of using landmarks over using imaging. So because of that, I feel very confident doing what we do, and will persist with doing what we do until I'm told I can't.
Yeah. So the patient, the nurse practitioner who was shadowing me that we brought her smell back, she had, I don't know if I ever told you this, she actually had a stellate ganglion block under fluoroscopy like 2 weeks prior for anosmia. And it did not work. Mm-hmm. So for her to have the actual procedure and then come here and by chance see me do it while she was here and, like, let's try it. And to get her smell back is crazy, right? And I didn't even do it in her stellate. I did it right in her sinuses. Yes. So I think that's really important in that practitioners, sometimes when they don't really understand what we're doing, they got an opinion about everything until they're actually doing it. It's like, oh, I didn't realize that's what you were referring to. So I think the nomenclature of when we say a stellate ganglion infiltration, like when I'm doing a consult, I say, I'm not blocking anything. So before you go tell so-and-so that I'm blocking, we're not blocking anything. We're what do I say? We're inviting them. We're not bringing in a hammer. We're inviting them to help their body reset. No, I think that's perfect. Thank you. Let's talk a little bit about, so there's a couple different areas as far as where we do these infiltrations. Can you give us just some maybe clinical considerations of when would you do a stellate versus when would you do a celiac versus when you would do the inferior epigastric? Like what symptoms, what conditions?
So it's fascinating that you asked that, because some patients I would expect to respond better to a stellate respond amazing to the inferior hypogastric. So we say there's the neck injection, the stomach injection, and the pelvic injection, just for ease of explaining to patients. The neck injection is also the stellate. You've probably heard us talk about the stellate. You maybe heard people online talk about the stellate ganglion block. So what we're trying to do, it's called stellate because it's star-shaped. What we're trying to do is calm everything down. So it covers pretty much everything from the diaphragm to the top of the head. So anything that you might be experiencing diaphragm to top of head, you can treat with the stellate. So if someone's coming in with insomnia, if someone has headaches, if somebody has if they're having anxiety, depression, anything where they're mood related, fatigue related, anything where we need to recharge their immune system because of some sort of tissue damage, any trauma in their throat, we're going to start with that. So somebody who is coming to you saying, look, I have a lot of trouble expressing myself. I don't like to speak my mind in public. I don't like to ask people for what I need. Those might be patients that I would use a stellate in. So it's anything really. And then I also use those in patients who have heart rhythm irregularities, breathing difficulties, anything related to those two. I'll also, so anything really from the diaphragm up, I'm going to treat. Heartburn, reflux, that's sort of thing that affects the esophagus because it's all in this upper chest area. I'm going to use that. And then the celiac covers anything, that's the stomach shot, that covers anything from the diaphragm to the bottom of the belly button, the bottom of the umbilicus. And what we're trying to do there is treat anything that's intestinal. So I'll do, again, anything related to the stomach ulcers, any SIBO you might use it for. You could use it for anything small intestinal. So if they're not absorbing things well, if they have any sort of nutrient deficiencies, we might use it for that. What we're trying to accomplish there is, and things like Crohn's disease, ulcerative colitis, et cetera, this is in conjunction with all the other things that we're doing for those disease states. This just might be an adjunct that would help calm down that sympathetic nervous system. Because when you have those ulcerations or traumas to the inside lining of the intestines due to those disease states, we're going to end up giving the patient, that's going to continue to send sympathetic signals to the brain saying, oh my gosh, everything's terrible, which is going to create more inflammation. Like henny penny, oh my gosh, the sky is falling. So if we can turn down that henny penny response, then we're allowing everything the natural ability to heal itself. And then if we're going to treat the pelvis, we do anything that was pelvic injury from the belly button down. And that would include the legs as well. So any sort of, anytime you've had a childbirth would be something, PCOS or endometriosis, we're going to use this for that because those are both sympathetic nervous system dominant related. If you look up, there's tons of articles on the internet about the relationship between the sympathetic nervous system and that. And again, these aren't the things we're doing all by themselves. Neurotherapy is an adjunct therapy to turn down the continuous signal of stress that the damaged tissue is sending to the brain. Anything that's sort of sciatica, anything like that, all of that we're going to treat with a pelvic shot. Infertility, benign prostatic hypertrophy, getting up at night to urinate, any decrease in libido. And lots of people will talk about holding tension in their pelvis. There's a lot of emotions that get stored there from childhood activities, from maybe abuse as a child, or from having from things like abortions. There's a lot of emotional trauma that's stored there. And when I say emotional trauma being stored, the insult itself, the surgery or the traumatic insult itself, but also the emotion that's attached to that, so that the healing that occurs is partial. It's a lot of fibrosis. The fascia, the coverings around all the organs are sort of bunched up instead of being smooth and healing well. So what we're trying to do is restore the natural healing to that area. And that's what we'll see with the pelvic shots.
Yeah. So one thing that we do also see, and I'm sure you've seen the study, is vasomotor symptoms. So I think about sometimes those hormonal patients who maybe aren't ready to go on hormones, or, maybe they're not a candidate for hormones. I think the study is, well, the stellate does not change the frequency. It can improve the intensity of the vasomotor symptoms, which I think is huge. The other thing we see it really well in is patients with menstrual migraines. Like that can be a game changer for many of those, those women in particular. And then constipation. So, I feel like the whole world's constipated. I live in the Midwest, so everyone's even more constipated. And so I have a patient, she calls it her belly stelly. And she has found significant improvement with bowel movements and bowel regularity on that. And then in the pelvic region, another thing that we frequently see too is interstitial cystitis. We've also heard that with actually a very low dose of like 4 or 5 milligrams of methylene blue at night can be really helpful for those types of patients. And then one thing I started doing is when I do the O shot, I actually will like set the scene with a pelvic injection of neurotherapy. And then when I actually go in to do the clitoral block and block the menorah, is I actually will use 1% with bicarb of procaine to block it. And women feel very relaxed, very at ease. And so I feel like, I mean, that's always like an uncomfortable, nobody likes to be in the stirrups. Okay. Nobody likes to. And then I'm coming at them with like a headlamp. So it's like even less fun, but it does help. It does really, really help. So if you are a provider listening and you offer O shots, I think it'd be a great option to swap that out to a little bit of procaine. But
and a couple of patients we've had that have had some postmenopausal bleeding due to use of hormone replacement therapy, despite turning down their hormone replacement therapy to the very lowest that they tolerate that controls their symptoms, might still be having some vaginal bleeding or whatever. After we send them to be cleared that there's nothing else going on, endometrial biopsies, ultrasound, et cetera.
Yeah.
As long as all that's normal and they want to continue their hormones, then we can get the bleeding to stop by using a pelvic shot. So that's been really great. And probably every 6 months they require it. So they end up not having to have a hysterectomy for no reason, no major surgery for no reason. And they're still able to do their hormones, which is great.
Yeah. We also even use it in some of our male patients who are like leaner, like I'll say the avatar of like my husband, right? There's not a lot of fat anywhere on that body. But every time we do a pellet procedure, it causes trauma to the tissue. And so in our SCAR protocol, we do procaine with 20 gamma of ozone, and we take our acoustic wave and, we like break it down. And I think that's been a game changer for not only the retaining of those pellets in the body, but retaining those male patients. So this way they, can stay consistent with their testosterone and don't have to jump to other modalities. Which I think is huge. I think that's super, super helpful.
And you're doing that after their pellet or before their pellet?
So we do it like when they're in, we pellet one side of the cheek, and then we just treat the other side while they're here. So we're always rotating it. So it's kind of like one side got treatment and the other side's getting actually like their pellets. And then the next time I see them, vice versa. And we've seen a great lower incidence of pellet issues like scar tissue, seromas, like none of that. That's awesome. Which is hard sometimes, Suzanne, in that, you and I train practitioners all the time and they're like, what's your SCAR protocol? I'm like, well, you're going to need procaine, ozone, an acoustic wave. It's like, unfortunately, things that are not super common in offices. And so, but if you can, it's amazing. Like it's very, very, and we use that in our like MSK protocols for joints using things like procaine and peptides and ozone and acoustic. So as a business owner, it is a modality that will have multiple layers of benefits if you can, I call it like cross-pollinate them into all the services, which I think is super helpful. Next question I had is, so how soon do patients notice benefits? Is this like the first treatment? I already know the answer, but I want you to say it. Is this like 12 treatments? When will people start to notice?
So I notice a benefit in me when I use procaine. If I use 2 milliliters of 1% procaine, so a tiny little bit, within 5 minutes. It's really fast, which is nice because then you got it in the right place, right? You know that you've done the treatment that needed to be done for that patient. So the problem is it doesn't last a long time. And so that's why the repeated, when I say 8 to 12 or 15 treatments, you're going to have to, it's usually weekly, and I make people commit to 3. And often you'll get a longer result every time you treat them. So the first time you treat them, you might get a day, which is, we know that's due to the procaine because the procaine only lasts for 20 minutes. So it's the metabolites of procaine that are causing that day of benefit. And then you do another, a week later, you're going to do it again, and you might get 3 to 5 days of benefit. And a week later, you do it again, and you might get a week to 10 days. So with some of my patients who have sort of a chronic PTSD, I treat them 12 to 18 times weekly. And now I see them every 6 months. They're like, yeah, just last week I started to feel a little stressed again and noticing I'm not sleeping quite as well. And so they come back in for their reboot and they do just fine. That's all they need is one treatment. But I do make people commit to 3 in order to really see the benefits.
Yes. Is there any additional like questionnaires, testing that you do prior to initiating therapy? And I only ask that because we do a GAD-7 on anyone getting neurotherapy, only because it's hard to identify or quantify, I feel like myself, or I feel calmer. It's hard to put a number on that. And, as people who want to show data, look, if I do this, it will yield this result. It's really hard to do that when you're asking people how they feel. So we do a GAD-7, and it's been amazing. It's free, it's easy, it's 7 questions, it's super easy to do. But are there any like testing things that you track or measure to track the progress?
Well, that's exactly one of the things we do is the GAD-7. We do an MSQ on our patients, but the GAD-7 we definitely do. I love and it really adopted the phrase, what are you noticing? Because how do you feel, or are you feeling okay? Are you feeling okay is a yes or no question, right? Yes, no, I'm not, whatever, feeling okay. How are you feeling? Good, because most people say good in response to that. But what are you noticing is a really great question. And I tell them between treatments, will you pay attention? I just want you to notice. Do you get angry when your husband leaves the socks on the floor anymore? Do you notice that your vision is improved? Have you noticed that you're not having to get up to urinate as often?
Yeah.
Do you notice that? So just pay attention to your environment. And even things you think that might not be related, bring them up when I see you next time.
Yes. Yeah.
So they'll say, I have asthma and I just noticed that I haven't had to use my inhaler as often. Procaine is antihistaminic, so it should have that benefit.
Yeah. Yeah. One of the things that I often tell patients is, well, I can't change your circumstance. I can change how your body is thinking and processing through that circumstance, right? Like your husband's going to be your husband. Your kids are still going to be your kids. They're going to still need a ride to practice. Your mom's still going to need you to do this, but it's just going to change how your body is responding to all those stimuli in the environment. And hopefully you're able to feel more managed. And I think that is when patients come back and I ask them that, they're like, you're right. Like, I'm not that mad about whatever shit happened right before they walked in here, which I think is a very like telltale sign. They're like, I can't think of a bad thought. I'm like, that's great. Let's just keep that momentum alive. So after they do their initial 3 with you, do you typically like bring them back in 4 weeks? Do you bring them like later? Do you let them decide? When do you typically, so if a patient's listening and they're like, okay, well, I did my first set of 3 with Lexi, like, how do I know when do I need to go back? What would you say?
So it depends on what the reason is for their, it depends, unfortunately, is the answer to your question. If they're 100% better and their symptoms that we were initially treating are resolved, you do not need to treat again. If they have any residual symptoms, I would keep treating weekly. And then patients are going to start to self-select, meaning they're going to go, do I really have to come back next week? Because I'm feeling pretty good. Or they'll cancel their next appointment. They'll be like, I don't need to come, because who wants to come in and get a shot if they don't have to? Right. But if it's making them feel better, they will be persistent. So the patients, at least in my experience, the patients who need it will continue to come weekly until they don't need it anymore. And even the PTSD ones, after about 12 weeks, they'll start coming in. They'll start saying that, like, hey, do I have to come in next week? Because I'm feeling pretty good. No, just go. Let's see how you do with 2 weeks. If you're feeling amazing, just cancel your appointment.
Yeah. Yeah. Oh, definitely. Definitely. You had mentioned about like the release. We, in our office, we call it lightning. I don't even know where lightning came from. I don't know if that was a term you said, or maybe we read it somewhere. And so lightning is where patients can sometimes experience it during their 20 minutes of hanging out in the Zen den. But have you had many patients have it like a week later in like at home, at the roundabout, like in carpool lane, and they're just sitting there, and all of a sudden it's like, and what release is it's almost like they get overwhelmed with their emotions. They might even cry a little bit, but they're like not mad about it. They're like, oh, I feel better.
Yeah.
Do you see that like often not in the patient room?
Yes. We'll see it a day or two later is super common where they'll be fine, fine, fine. And I don't know if that's because it's harder to access. I don't know if it's because the metabolites are what's getting to the problem, or if it's because they are holding back, not a lot. They're afraid to have an emotional response. I mean, a lot of people really are. I am, how many of us, when we start crying, we go, I'm sorry.
Yeah.
Right? We're apologizing for having emotions.
Mm-hmm.
Anyway, we all do it. And so they will hold that back. They get home, they get in their carpool lane where they're by themselves, and all of a sudden, right?
Mm-hmm. Yeah, I had a patient send me a portal message. She's like, I just got home from drop off. And she's like, there was nothing sad, but it was very peaceful afterward. I was like, that's great. I'm so excited for you. And so then I started telling patients, like, this might happen. If it happens, it's not a big deal. And then they're like, it's not scary. Like, it won't be scary. But if you happen to have a little good cry here and there, that might be part of it.
You're welcome.
Yeah, yeah, which I think is so funny. Okay, so we've talked about that the GAD7, the MSQ. When someone is getting a stellate injection, how do you decide which side you should start with?
So I feel like most of my patients do better when I do the left side, but I will start with the left side. That's the reason, unless they have a particular reason. Like, I always have symptoms on my left side. I always have symptoms on my right. Every time I have anything, it always happens on my right. I'm going to treat the right side. Whichever one, it doesn't really matter. The next week when they come back, I'm going to do the other side. And then I'll say again, pay attention. What are you noticing in this week? And when they come back, what did you notice in the last week that it was different from the left side to the right side? Do you have a preference? Did either one make you have any sort of other feelings that you didn't notice or whatever?
Yeah. And then can you talk a little bit about the Horner's response, what that is and why it happens?
So it's a expected response. When the sympathetic nervous system is working, it keeps your face alight. It keeps your, all the muscles tensed up a little bit, so that we can all be paying attention to our environment around us. That's where it comes from. When the sympathetic nervous system is turned down, which is what we're doing, you might feel some heaviness in this side of your face. You might feel change in the shape or the size of the pupil, some flushing in this side of your face, some congestion in the side of your nose where the stellate was done. So all of those are normal responses. Thankfully, with procaine, they only last about 20 minutes. So you're getting this like softening of this side of your face, of all the sort of tightened features. You're getting changes in the congestion in the nose, maybe some facial flushing, and all of that is the completely expected Horner response. What we've found lately is even if we don't get a Horner response, but the patient's like, oh, I feel so relaxed, which most of them do, or I feel calm, or I feel safe, or I feel euphoric. Those are all words we've heard. Then we'll count that as the Horner as well, as a response to the medicine as well.
Yeah. Can you talk a little bit about like the mindset of receiving? I feel like this is important in that, like, I had a husband-wife, and the husband having amazing results with neurotherapy. He's just like, this is like for him, like what I feel like I've been missing in traditional medicine for a very long time. He's been able to get off meds. And so he wants his wife to do it. And the wife's like, well, there's really nothing wrong with me. Right. And I told her, listen, there doesn't have to be anything wrong with you. It's just a great way to help your body relax and get into a parasympathetic state. But it was almost like she went into it with her mind like, I don't really need this. So when she woke up, she's like, I feel the same. So can you talk a little bit about why that's important to address leading up to it?
I think it's all in the provider's approach to the situation. I love the fact that y'all have the Zen Den. That's great because you have like the binaural beats going and the lights are turned down a little bit low. We have cafe lights in our rooms. You know, it's just this extra room that's really chill where everybody's sort of, and you're talking in a slower tone, you're talking in a lower tone, you're very reassuring. You take a deep breath with the patient. So we always tell our practitioners that we are training like, take a slow, deep breath. And so it's like, but you have to do it with the patient so that you get calm before you do it, all of that stuff. And I think that it's just like if you have given someone a Xanax for something, and if they're so anxious, they can throw it off too. Even though you've given them a benzodiazepine, they can also throw it off because your sympathetic nervous system can be so strong that there's not enough procaine to suppress it or to block it or slow it down. And so if there's that high sympathetic drive, you're not going to get it. It doesn't mean you're not getting benefit. It just means you're not going to see that same thing. So those are patients I'm going to bring back. It may be the case with this patient that you described that she actually didn't have a need for it or benefit. Maybe she does have a good balance, but you know her better probably, and her husband probably knows that she probably maybe did.
Yeah. What would you say most common side effects?
Calm, euphoria, safety. I had a patient say, I feel safe for the first time in my life. I know, makes you cry. It's so sweet. Other things that people experience, they may experience sort of a hoarseness of their throats, congestion in their nose. They might start to hear their stomach gurgling. For a few minutes, they might have their heart rate rise. And I tell them that's so that we can move the procaine around. Your heart's helping us move the procaine around. And then they will experience the strong emotional response can occur. Sometimes people will cry. Occasionally people will have a little bit of difficulty swallowing because one of the things that the sympathetic nervous system does is hold the vocal cords open so that you can pass air through and talk. When you turn down that sympathetic drive, you're causing that vocal cord to close across the airway. And now it feels as though you can't breathe or can't swallow, neither of which are true. You can still breathe and swallow, but it's just an uncomfortable feeling. And you do still have the other side open. That's why we only do one side when we're doing stellates. We only do one side at a time. Because we want to make sure that one side is able to function. It takes about 20 or 30 minutes for that effect to go away. I think the longest I've ever seen that difficulty swallowing, it was about 3 hours before it went away. So that was the worst I've ever seen. And just that can sometimes happen. Sometimes people will get symptoms into their arm, and that may indicate that we've infiltrated to their actual C6 nerve root in addition to the stellate. Sometimes it's really thirsty. So whatever tissue is there that needs it, we'll take it up. If that's your muscles in your neck, if that's the nerves around that supply the airway, if that's the nerves that supply this arm, whatever's the most thirsty is going to take it up. So that's where I'm going to see a lot of some of the side effects. And it's less a side effect and more an effect. So I always say, you're welcome. That's what we're going for, is improving the nervous system in that area.
Have you ever had a patient also ever use ketamine, not in conjunction at the same time, but like has had ketamine and has in neurotherapy? Because I haven't. I'm curious to see what your patient's feedback was.
I haven't had anybody do both.
Okay. So I've had two, and they both had said that they wish that they would have known neurotherapy was around because they would have preferred that first, in that neurotherapy is very calming, very relaxing, and very safe. And ketamine for them was very scary, very, very scary. And, it causes your heart rate to go up. And he's like, he just kept saying like, it's just like your body's on overdrive, right? And you want to jump out of your skin. And he said, that's not like that at all with neurotherapy. Like, which I thought was, and I've had a female and a male both tell me that. Which
That makes sense, because if you want to be in control, ketamine doesn't really allow you to stay in control. Where I think you do, unless you're doing an IV. The IV procaine, you get that sort of G-force feeling when you do IV procaine, and it's primarily if you run it quickly. So you can always slow that down, and the patient has control over slowing that down. So then they're fine, as long as they know they can.
Yes. Final questions. Who is not a candidate for neural therapy?
Somebody that was allergic to procaine. Now that has to be specifically procaine, because procaine is a different local anesthetic than lidocaine, bupivacaine, tetracaine, all the others. If you're allergic to those, you may not be allergic to lidocaine. It also may be that you're allergic to the preservatives in the local anesthetic, and not actually to the cane itself. So it's pretty rare to be allergic, but an allergy would be probably the number one. You can use procaine in breastfeeding and pregnant women. I prefer not to, just because I don't want to be related to that at all, unless we absolutely have to, and we get the approval of their OB or their pediatrician.
Thank you so much, Suzanne, for taking the time to help go through some of this education for patients, practitioners, listeners. There are so many people, practitioner-wise, who want to get trained in this. And I just send them to your website. I'm like, I don't train in this, but this is who does. Where can people find you? And I'll make sure I'll tag everything. So you are on Instagram. Do you know?
At Dr. S. Furee.
Okay, good.
DRS Furee. And then on our website is Vine, as in grapevine, medical.com. And you'll find the conference there. You can also email Jenna at vinemedical.com if you're interested in attending.
Perfect.
Or DM me through Instagram.
Yep. And you also have a virtual platform as well, correct?
I do, exactly. So if you're interested in doing, I think the hands-on is really critical, but if you want to do the online program, it's available online. There are videos of how-to videos on there. And so you can find that on leaderpath.com/Suzanne Furee.
Yes. Yeah. And then I know that you teach in conferences, where are you speaking next?
Okay. So the next one is Concierge Medicine Today here in Alpharetta. And then I'm teaching in Clearwater at the Vitamin C conference. And then in California, November 7th at the Frontiers in Ozone Therapy Conference.
Yay! All the things.
Oh, yeah. And A4M. I'll be at A4M.
Perfect.
Yeah.
All right. Well, thank you so much. I always appreciate your time to help educate and continue to build the next wave of practitioners, and giving them additional tools for their practice that can help patients beyond what traditional medicine can offer.
Thank you, Lexi. I always learn little pearls from you. Thank you so much.